Hello everybody, welcome back to Pathology. Today we are going to go through a brief overview of neoplasia. So tumors are either benign or malignant. The benign tumors are importantly encapsulated, as you can see here, with a normal stroma. So they are a normal capsule, a normal collagen, but inside there is parenchymal changes. In a malignant tumor, there is both parenchymal and supporting stroma changes. As you can see here, this is an invasive carcinoma nest, so there is no neat stroma, as you can see here. Here you can sort of see bands of collagen, some kind of supporting stroma, but it's not organized. So brain tumors, basal, and squamous cell carcinomas are all malignant by location. And all tumors have neovascularization. So malignant tumors are going to be unencapsulated with, disorganization. Besides gliomas, this is one of the exceptions. This is a tumor in the brain, especially of the neurons or in particular the glial cells, and just by definition, they are malignant. Sarcomas are going to be of mesodermal origin, and they're defined by spindle cells. And vimentin is the connective tissue marker, while desmin is the muscle tissue marker. You can kind of remember it by desmin is one of the proteins needed in the muscle. Carcinomas are going to be characterized by nests of cells, like here, and they're going to be filled with cytokeratin, and in the liver, they're called Mallory bodies. They can be ecto or endodermal in origin, and all the tumors are going to be described as Dysplasia, in particular, like the carcinomas, because they are muscle tissue, and desmin is the marker, so Dysplasia. So excessive fibrosis. And it can be defined as fibrosarcoma, chondrosarcoma, and osteosarcoma. So this could be either in muscle, connective tissue, or cartilage and bone. Okay, so oma generally means benign. So glioma is not, though, and hemangiomas are not. This is because these are malignant by these are benign, but they are not encapsulated. The adenomas are always going to be encapsulated. Adenomas are defined by the presence of glands. Polyps are the adenoma of the colons, and papillomas are when there are no glands. So here's a benign tumor. There's the capsule, and then when it invades, there's going to be ulceration of the skin, and then lymphatic invasion, and there's no more like nice capsule. Here, this is a fatty tumor, so this is an adenoma. Or lipoma, I'm sorry, that is a lipoma. Okay, so the other omas we should know about are the teratomas. They are benign, cancerous tumors that are made out of more than one germ layer. So these can either be the mature cystic teratoma, as you can see here, it's full of other tissues, and there is the dermoid cyst. Immature teratomas will contain embryonal tissue, and of course, those can be of any origin. Pleomorphic adenomas are benign mixed tumors that are made of both epithelial and stromal elements, and those generally affect the parotid gland. The epithelial ducts, acini, the sheets of cells in the background can show myxoid areas, as you can see here, that contain cartilage. So right here, this is the pleomorphic adenoma. Right here, the myxoid areas. And this is encapsulated, as you can see here. Okay, so Anaplasia, the definition is there's no differentiation of the tissue, so it's all a mess, really. There's no organization. Pleomorphism is the characterization of the cells where there are a variety of sizes and shapes of both cells and or nuclei. So the problem with this is it can lead to this ischemic necrosis because there is no organization of the tissue. There is neovascularization, but it's not effective. The cells are going to be defined by hyperchromatism. So the nucleus is going to be very dark. Keratin pearls may exist, along with the intercellular bridges, as you can see here. Oops, sorry. And there's going to be a loss of polarity in some of the cells. So, mast cells should be polar, but their nuclei instead would be in the center. Here's more keratin pearls. Okay, so neoplasia continued. Chorostomas are normal but ectopic tissue. So one of the examples are Merkel's diverticulum, where there's pancreatic tissue in the intestines. Hematomas are disorganized but benign masses made out of the cells indigenous to the sites. So they would be like polyps in the GI epithelium. So the polyps are made out of the right GI epithelial cells, but they are not in organization. So you treat these by surgical removal. Dysplasia is more concerning because first normaloplasia, then hyperplasia, in response to usually some kind of injury, but dysplasia is when there is disordered growth. And in these cases, a carcinoma in situ can form where the entire thickness of the epithelium is involved. So mild or moderate dysplasia is reversible, so that's a good sign. But if infected with something like HPV, it can easily transform into like malignant cancer. So HPV is pretty common. It's sexually transmitted, and we test this in females by the Pap smear. So this is going to be your normal Pap smear. This is an abnormal cells, because there is the hyperchromasia and the enlarged nuclei. We use the cells at the squamocolumnar junction of the vagina and the cervix to test. Okay, so the tumor growth rate depends on what kind of cell it has been mutated and the location, of course. So something in the skin or in the mucosa will be growing much, much faster than something in like muscle tissue, right? Because the muscle tissue turnover is very slow. It takes decades for muscle cells to die, while in mucosa it takes about a couple days or a week for the turnover to occur. So the uterine fibroids are like one of the examples. So anti-cancer drugs will act on the cells that are in the cell cycle. So we want to block it at certain checkpoints. Rapid cancers that we need to pay attention to are leukemia, lymphomas, and small cell carcinomas. They're all malignant and they grow pretty fast. Except for the leiomyoma, those are not malignant sometimes, it depends. And they are pretty slow. And they are the largest in pregnancy due to the estrogen, and after menopause they can become calcified, so they can be benign. Other slow growth cancers are colon carcinomas and breast carcinomas. We need to be careful of these because once you actually catch them, that's usually a bad sign. That means that they've metastasized, and that's usually when we catch these diseases, because patients will come in complaining of very non-specific symptoms like, oh, I feel tired, I feel achy, but it's hard to narrow down due to those symptoms. Okay, so benign tumor cells don't invade or metastasize, they just grow larger, and they have a thick fibrous tissue capsule, which differentiates it nicely from normal tissue. The malignant tissues, of course, will invade and destroy the surrounding tissue, and when it first goes to one lymph node, that's the primary tumor. There's one nodule, but when it's starting to be multinodular, that's when it's metastasized. So once they've invaded the other extranodal sites, there is dissemination. So the malignant tumor will enter the circulation. It will colonize where there is a good amount of blood supply and nutrients, and due to serine, cysteine, aspartyl metalloproteinases, it will degrade the ECM of the neural tissue and allow them to implant. So there are complications even with benign tumors. They just get too large and then they will compress on vessels and organs. The important ones we want to pay attention to: the pituitary and the optic chiasm. Optic chiasm cause blindness. Pituitary, it can cause diabetes insipidus and problems with sex hormone release, vasopressin release, etc., etc. But usually the first sign is diabetes insipidus. Anything compressing on the ventricles or the CSF pathway can lead to hydrocephalus, and of course that's problematic. Okay, so the seating of the body cavities and surfaces generally would be the peritoneal cavities, the ovaries, and the appendix. And if you seed the peritoneal cavity, the patient develops pseudomyxoma peritoni, where there is primary mucinous tumors that come from the appendix, and the appendix can reseal, reaccumulate, bust, and do it all over again. And they will go to areas that absorb the peritoneal fluids, such as the omentum, and then they proliferate and they make even more mucus. And this is going to be a problem in digestion and just compression in general. They can also see the subarachnoid space and cause acute lymphoblastic leukemia, glioblastoma multiforme. Other pathways that cancer can spread is through the lymphatics, and that's the primary method of colon carcinoma and breast carcinoma metastasis. Lastly, the lymph node enlargements is one of the first signs of metastasis because they are going to be reactive hyperplasia due to the additional cell debris and the tumor antigen. So they're going to be overworked, so the lymph nodes will be enlarged. Spread through the blood is typical for the sarcomas. Usually the veins are involved, especially the ones that lead up to the internal vena cava to the right heart. So there is usually some kind of right heart failure, as you can see here. Vertebra metastasis is particularly significant in thyroid and prostate carcinoma, because the renal cell carcinoma involves the renal vein, and it can spread through there because remember the renal vein and the renal arteries will provide the gonads. Okay, so continuing on with the epidemiology really fast. So a lot of cancer is due to genetics. One of the important ones is the childhood retinoblastoma, and that's a mutation of the RB tumor suppressor gene. There is always a risk for the segment malignancy, which is more commonly osteogenic sarcoma, and familial adenopatous polyposis. There's a mutation of the adenomatous polyposis coli tumor suppressor gene. And then the other genetic cancer would be the Lee-Fraumoni syndrome, where there's a germline mutation of P53. And then there is MEN1 and MEN2, where there is mutation in the RET Protooncogene, and that's going to lead to thyroid, parathyroid, and adrenal gland cancer. So, familial cancers will have an early age onset, and the important ones you want to know are the breast carcinoma. So, these are the most famous ones. BRCA2 and BRCA1, those are the markers for that. Familial melanomas is P16INK4A. And there is always that two-striped hypothesis where one bad gene is inherited, and then the mutation eliminates the good gene and growth control is lost, allowing only like the bad gene to continue. Other causes of cancer is when DNA repair is impaired. It can be due to HNPCC, where the repair mechanism is defective, and this is autosomal dominant. Leads to xeroderma pigmentosum, along with ataxia telangiectasia and Bloom syndrome. Other predisposition can be due to medications such as aspirin, chronic diseases such as Sjögren's syndrome, Hashimoto's, cholelitosis, infections, HPV, H. pylori, Epstein-Barr virus, like that one too. Okay, so before there's full-blown cancer, there's leukoplakia changes where there is like whitening of the mucosa, and there's chronic irritation to tissues, which causes the changes. So in particular, there's the squamous to columnar change in the esophageal cancer, and then the precancerous stage goes and starts into like dysplastic syndrome, affects the primary nodules, and then there's going to be a laydown of a lot of collagen. So even though there is not like a capsule formed in something like dysplastic syndrome, there's still like excess collagen laid down to form that stroma, and the scar tissue can hypertrophy, and that leads to like ischemia. There's atypical hyperplasia, like I said, with the laydown of collagen and the unregulated, like disorganized growth. And there are other causes of cancers, such as the non-lethal genetic damage acquired. So this is more during like lifestyle changes, environmental elements. And these aren't going to be passed down to the children, so this is not an inherited germline mutation. So in general, there's going to be a monoclonal expansion. So there's one cell that starts it all due to some kind of genetic damage, right? And then the tumor progression occurs when subclones arise from the original malignant clone. And the subclones can differentiate in invasiveness, metastatic potential, and response to therapy. So we do want to catch cancers before they have metastasized too far, because like one kind of type of chemo isn't going to work. So the diagnosis is production of both isoenzymes of a particular cell, because in general, when they differentiate, they should only produce one isoenzyme. So if you biopsy like a lymph node and there's like two different types, there's a problem there. So the targets of genetic damage would be your protooncogenes, your tumor suppressor genes, the apoptotic genes, and the DNA repair genes. Protooncogenes are going to be your growth factors, and they are normally regulated to regulate just normal cell proliferation and differentiation. And when they are mutated, they can produce an autocrine signaling loop where it is not subject to feedback. And there's going to be just an overproduction of growth factors in the tumors, and an increase in VEG, that is going to increase, angiogenesis. The undifferentiated tumors, of course, grow faster because there's no more checkpoints to check whether this needs to be differentiated into this or that. Receptors can also be mutated, so the growth factor receptors can be overexpressed or activated by mutations or gene rearrangements. Several alleles for the oncogene receptors themselves can be mutated, causing the activation or expression of the growth factor receptors. ERB-B1 is going to be the overexpression in squamous cell carcinoma of the lung and glioblastoma, while ERB-B2 is going to be an overexpression of the growth factor receptors in breast carcinoma and ovarian cancer. So B1 can be anyone. B2 is for women. Oncoproteins are that mimic the normal functioning of certain signal transducing proteins are going to, of course, increase the amount of cell proliferation. So one of them, RAS. RAS is a normal oncogene, and that increases mitogenesis and is normally regulated by growth factors. So the mutation of RAS, such as KRAS, that's going to increase the proliferation of cells in the colon, the lungs, and the pancreas. HRAS, it's going to affect the bladder and kidneys, and NRAS is going to be melanoma along with hematological malignancies. So the tyrosine kinase pathway can be affected too, especially in a translocation from chromosome 9 to 22. The fusion gene BCR-ABL is formed, and that's going to increase the tyrosine kinase activity, and from that it can increase, the MYC gene. So that's going to make more cells, and it's going to decrease like P53. P53 is going to prevent these cells from proliferating by inducing apoptosis. So these are going to inhibit that. The drug imatinib is going to mesylate, is going to target the BCR-ABL gene in order to decrease the activity. Okay, so c-MYC is a very common gene to be affected because it is a transcription factor for cyclin D. Cyclin D is important because cyclin D will help the cell continue through the G1S checkpoint. So we want to block cyclin D, right? So in retinoblastoma, that gene is going to block cyclin D, and then that stops the checkpoint. But if the retinoblastoma gene is mutated, then there's going to be too much cyclin D occurring. Or in Burkitt lymphoma, there's going to be a translocation that is going to inactivate it. Cyclins, I just kind of went through it again. The most important checkpoint is G1 to S, and dysregulation is going to form the neoplastic transformation. Important one to know is the retinoblastoma. Okay, so back to ABL. Chromosome 9 is responsible for the ABL loci and is activated by chromosomal translocation, and it would lead to chronic myelogenous leukemia along with acute lymphoblastic leukemia. Can be activated by RAS, by the point mutation, and RAS is going to be allowing the tyrosine kinase to be activated and pass through the checkpoint. There's also the activation of PI3K and BRAF serine threonine kinase. That kind of does the same thing. The increased expression of MYC will induce the growth gene and deregulate the other proteins, along with amplifying the genes coding for proliferation and increasing the activity of the upstream signaling path. So mutations that also increase the CDK4 and D complex is also going to allow the cell cycle to progress. Okay, so that's it for now. Thank you for your attention and good luck studying.